Hello and welcome to Keep Talking, a community dialogue about mental health. My name is Gay Maxwell, and I am the manager of the Office of Continuing Education at the Brattleboro Retreat. The Brattleboro Retreat is a 182-year-old psychiatric and addictions hospital located in southeastern Vermont, where it serves children, adolescents, and adults in a variety of inpatient, outpatient, partial hospitalization programs and residential programs. The Brattleboro Retreat provides care and courage when being human hurts. Today I'm welcoming on Keep Talking a gentleman by the name of Dr. Stanley Possick. Welcome to Keep Talking. Dr. Possick will be presenting tomorrow to over 90 mental health clinicians from all over New England, and you'll be presenting on the topic of listening to the person with schizophrenia. You are a psychiatrist and a psychoanalyst, an associate clinical professor of psychiatry at Yale University, and a member of the faculty of the Western New England Institute for Psychoanalysis. You've had a distinguished clinical career at Yale Psychiatric Institute, as well as the mental health clinic at Yale Health, and you've received numerous teaching awards at Yale University, at the American Psychoanalytic Association, as well as the American Psychiatric Association. So I'm really thrilled to have you here, and thanks so much for giving so freely of your time to Keep Talking and to the Brattleboro Retreat.
That's my pleasure.
Thanks. We at the retreat launched a campaign about 2 years ago, the Stand Up to Stigma campaign, which is an effort on our part to educate the public about mental illness and addictions disorders, and to encourage people who suffer from mental illness and from addictions disorders to be courageous, more courageous, or to feel more courageous that they can get the help they need without feeling shame and fear. And I thought, here we are, we have this expert coming to speak about schizophrenia. And what other diagnosis is more steeped in stigma than schizophrenia? We have very strange beliefs about it, very strange ideas about it, probably based large part on television, on the media, on movies that we've seen. And so I want to talk today about schizophrenia so that perhaps people who are watching today can develop more compassion, more understanding about what it means to suffer from this disease. So can we just start off with, how would you define schizophrenia? What is schizophrenia?
Well, the current thinking about schizophrenia is that it's a neurodevelopmental disorder, which means that it's a disorder that has a heritable basis, it has a genetic basis to it, but that also that phenomena that occur either during pregnancy or after a person's born, moving into late adolescence, that things that happen to people can affect what occurs to them in terms of the onset of the disorder, or even if someone develops it fully. So that it is, it's a disorder that actually has several stages. Typically, when a child is born, there's no evidence of schizophrenia. There are no symptoms, and the only thing that one might find early on would be that there might be some mild cognitive changes. That is, people might not be able to do as well academically as one would hope. The second stage of the disorder is called a prodromal stage, and that can begin anytime during adolescence. And what you normally see is that that kids they'll be maybe more socially isolated, they'll have a harder time at school, they may feel down in the dumps, their thinking doesn't seem quite right, but it's not psychotic. Often they'll be using drugs, which can make things a lot worse. But this is a stage in the disorder in which, if one recognizes that there are problems, you can intervene. You can do things to provide supports for the family and for the child, and often that can attenuate some of the symptoms they're having. The third stage of the disorder is an acute psychotic stage, where people have a variety of symptoms that have to be dealt with. And there are basically three kinds of symptoms. There are what we call positive symptoms of psychosis or schizophrenia. That's mostly hallucinations where you have perceptual distortions like hearing things that really aren't there, or delusions where you have beliefs that seem to be accurate but they're inaccurate.
Why would they call those positive?
They're positive because they add something to what you'd normally see in a person. It's as though, you know, something more is happening than would be normal. Negative symptoms refer to something being deleted. So, for example, people will, their emotions will seem flatter than usual, or they won't have the same level of activity. They'll seem as though they don't move as quickly, they move much more slowly, they think more slowly, they feel socially isolated, they don't feel things at all. So those would be negative because something seems to be taken away. And then the third set of symptoms are cognitive symptoms. What I mean by that is that people typically don't have the same kinds of executive functions of the mind that they would normally have. That is, they can't plan well, they can't organize their thoughts necessarily very clearly, their judgment is off. They also have trouble with their memory, particularly their verbal memory. And third, they tend not to attend to tasks very well. So they have attentional problems. Those symptoms can become serious enough so that people may require hospitalization. Typically, they require a combination of medication to reduce symptoms, and the antipsychotic medications we use primarily affect the positive symptoms of psychosis, namely hallucinations and delusions. They have a lesser effect on the negative symptoms I've mentioned, and they don't particularly affect the cognitive symptoms in any meaningful way. But in addition to medication, we have a wide range of psychological and rehabilitation resources we use, so that in general, in an optimal situation, people are not only getting medication, but the family and the patient are being educated. There are family therapy meetings to help the family cope with what's going on. The individual is getting individual kinds of therapy to help them deal with what's happening. And as the patient gets a little better, we try to provide support services to help them go back to work or go back to school or to re-enter the community. So there's a wide range of things there. And the goal is to keep the period of psychosis as short as possible. The other goal is that if we know that if we can catch somebody early in the course of the illness, either before they become psychotic or very early in the psychosis, that the chance of improving their prognosis is very, very high. So that, you know, we have much more hope that we can do something effective if we catch things early. So it's very important, even in the pre-psychotic phase of the illness, if the adolescent or if parents notice that something is amiss, that it really is important to try to get some help at that point, because it can really affect what happens later.
Wow.
And so what we're trying to prevent is people from getting to the place where they really have a chronic illness. So that by that I mean they can be in and out of the hospital, and schizophrenia can often have that course where there are relapses and then the symptoms remit and you go back and forth. But eventually there are a certain percentage of people who become chronically ill, and their functioning is really deteriorated. Often they're institutionalized, they really can't take care of themselves well, and they're, a lot of these people would be people who are unemployed and homeless. And so we want to prevent that situation from occurring. And if we take the steps I've mentioned, there's evidence that we can go a long way to keeping that from happening. Wow. for many people.
That's huge.
That's huge. Actually, about 14% of people who have a first schizophrenic episode recover completely. and don't have another episode within 5 years. But that's a small percentage. But we're thinking that with doing all of these extra kinds of things, by getting them well medicated, by using all the psychosocial services that we have available for the patient and the family, that we can really have an impact on the ultimate course of the disorder.
Dr. Possick, I've heard the term schizophrenia and schizoaffective disorder. Can you parse out the difference?
Yes. So schizoaffective disorder it's a form of schizophrenia. It's in the same spectrum. With schizoaffective disorder, you have mood swings, and it can take various forms, but the simplest kind to think about is a person having highs and lows, like depression and mania. And when they're in periods where their mood has shifted, they have psychotic symptoms like hallucinations and delusions. But also in periods in between those, when they're not either high or low, they still have psychotic symptoms. In more general kind of chronic undifferentiated schizophrenia or an undifferentiated form of schizophrenia, you may have some highs and lows, but that's not a major feature of the disorder.
I see. So I read on a site, and you can disagree with it. I'm going to ask you whether this is accurate or not. I read that the Center for Excellence in Community Mental Health, this is part of the Department of Psychiatry at the University of North Carolina Medical School, says that 1 in 100 people develop schizophrenia. Does that sound accurate to you?
It is accurate.
Wow.
It's about 1% of the population has schizophrenia. So, in this country, that's roughly 3 million people. And I think most people believe that number is true amongst most cultures, although I don't know that it's been studied in third world countries. But the 1% figure is, I believe, quite accurate.
I see. So tell me, is there a way, I think you answered some of this, but is there a way to test for this, to predict it in some way? Are there risk factors that families ought to know about?
Yes. So the first risk factor is if you have a close relative, a first-degree relative, whether a parent or a brother or a sister who has schizophrenia, your risk is increased of developing schizophrenia. That doesn't mean you will develop it. It doesn't mean that at all. It means that your risk is higher. So that, to give you an example, in the Scandinavian countries, they keep birth registries, and they have every diagnosis that a parent might have. So in looking at those registries, they can look at whether parents were schizophrenic and then look at the children and then follow the children and get a sense of what percentage of those children develop schizophrenia. So there were studies done in the 1960s where they looked at monozygotic twins, that is, twins who both come from the same egg, so they have the exact DNA. And they looked at those twins who were both reared together by their parents or reared separately to try to determine whether this was a genetic disorder. Now, you'd think with the DNA being exactly the same that if one twin had it, the other twin would have it. But that's not how it works. Roughly 40 to 50% of the people had it. So it was more than you would just predict siblings would have, which is what suggested that it was genetic. But it still indicated that, if it's 40 or 50%, that means 50 or 60% didn't get it. We don't know why that is. But it seems as though, so that the first thing you do is if you know someone has a parent who has schizophrenia, then you want to watch the child and you want to be looking for any kind of behavioral abnormalities or increased isolation, school difficulties, and immediately get people help.
So it would be important for pediatricians to know and school counselors to know.
Exactly. It would be important to know. And actually in the Scandinavian countries, they train pediatricians and elementary school teachers, and some in Finland in particular, to look for these signs in kids, when they're 5, 6, 7 years old. The idea being that if you can treat the children very early and work with the families, you reduce their vulnerability to stressors, and that may have an impact on the future course of the disorder.
And when you speak about the stressors, can you give some examples of what those might be?
Yes.
They could be anything, I suppose, but what have you seen?
Well, any kind of trauma or abuse is a stressor. I think those have been the most significant ones that I've seen in my clinical experience. I think if you're an isolated child, or if you have any kind of social difficulties, it's easy for you to become a victim of bullying. In terms of the current world situation, immigration tends to be a risk factor, and you're brought into a new culture. You may not be treated well, and that can really cause a tremendous amount of stress. And often in these children and in their families, their ability to deal with stress effectively, because they've been through so much already, is minimal. And so providing supports for them and doing what you can to minimize the stressors that they're having to face really can be extremely helpful. The other stressor, and I think the most important one, is substance abuse. So that in young adolescents who begin using drugs, and actually pot is the most serious one for them, we find that they develop schizophrenia, the acute psychotic phase of schizophrenia earlier than one might predict. So it might be in mid-adolescence rather than late adolescence and young adulthood. So that working with families and working with the individual adolescent who's having difficulty with drugs, particularly if they have a history of schizophrenia in the family, they're at very high risk to have a first psychotic episode. And so you want to work with those people as quickly as you can to try to minimize their risk or to reduce it.
When a patient comes to you,
Yeah.
do they often come of their own free will? I mean, do they often step into the office or by themselves, or are they often accompanied by a friend or a family member who's seeing something and urges them to come for treatment?
Well, that's a really interesting question, because in this prodromal phase, that is the phase of the illness that I've just been describing that occurs before an acute psychotic period, people want to be in treatment. Both the children and the family, they look for it and they seek it out. But it's not always as available as it is when someone is acutely psychotic. During the more psychotic phase, often other people, particularly family members, notice there's a problem. In the first place, if you're psychotic, one of the problems that may occur is that you become frightened of other people. And so you become fearful that if you let people know what's going on, things that you think may be real, but you sense other people won't believe are real, it causes you to be much more avoidant. So typically when people have moved into a psychotic phase of the illness, others have seen changes in their behavior or in their thinking that frighten them, and they usually bring these people in or bring them to someone's attention who'll bring the people in.
And you mentioned that during the phase before that,
Yes.
that people actually are seeking out help,
Yes.
but they're not getting it necessarily. What's happening there that they're not getting the help they need? Is that lack of child psychiatrists in the country, or?
Well, I think what needs to be done is that there need to be centers available in communities that really address adolescents who are in transition, adolescents moving into late adolescence, and who are coping with changes in their lives. In addition, one of the things that's been found to be really helpful with the more socially isolated kids is if you have community social activities and you help move people into them and support them as they do it, that also is very helpful. I mean, it's sort of common sense health hygiene that you want to utilize at that point, while at the same time identifying those people who you think are going to be at very high risk because of the family history.
May I ask you, when a patient describes to you what they're experiencing, what are the words they use? What are the phrases? What are the common threads that you're able to recognize as a psychiatrist?
Well, I can give you an example. Many, many years ago, when I was in training, I was asked to evaluate a person who was in a hospital bed. And he had just been admitted to the hospital because he drank a bottle of iodine. It had a poison label on it, and he wanted to kill himself. And I said, I asked him what led to that, and he said, well, you know, I can't feel anything. I just don't have any feelings. And he said, I can't live that way. I need to be able to feel things. Mm. And when I said, well, how long have you noticed this, and do you have any sense as to how this came about? He said, well, I think what happened was that when I was a kid, they cut out half of my brain. They cut out the half of my brain that deals with feelings. And he had a delusion about the people who had done it and why they had done it. Mm. And that was his explanation. So what was clear was that he was in tremendous pain, that he was having what we would call both negative symptoms of schizophrenia in terms of the absence of feelings, and positive symptoms in terms of having this delusion. Mm. And for him, that was the reality of the situation. That is, when he felt he didn't have any capacity to feel anything, he had to come up with a reason for it. We all need a sense of causality. We need to know why mm-hmm. something has happened. But his reason was based on a notion of the world that was distorted and didn't include a real sense of what was real and what wasn't. This was his reality, and he believed it fully.
That's a very powerful story. What are you listening for when you are trying to make an accurate diagnosis, and how long does an accurate diagnosis take?
Well, it can vary. What I'm listening for, I'm watching certain things. So for example, when I'm sitting and interviewing someone, are they making eye contact with me, or are they not making eye contact with me? If someone is sitting with me and his eyes are darting all around the room, that's often a clue that the person is frightened, but may be responding to internal kinds of stimuli like voices, so that it's as though they're hearing things coming from other parts of the room. Obviously, if someone tells you about hearing voices or describes the kind of delusion that I just mentioned, that can be very powerful. Also, people will, without necessarily describing these kinds of symptoms, will demonstrate evidence of a thought disorder. By that I mean that their thinking isn't logical, so that their associations from one topic to another just don't follow each other. There isn't a kind of coherence or logic in their thinking, and that can often be a sign of schizophrenia. Now, schizophrenic patients who are in an acute episode can also feel very sad, profoundly sad. They can feel profoundly suicidal. Often they're very paranoid and they believe that people are out to get them. In the most dramatic kinds of situations where you'll have what's called a catatonic state, a person may be immobilized and unable to speak or move or do anything for long periods of time, and may hold their bodies in bizarre positions. That's quite dramatic and not typically something you see early on, but that would be a range of the kinds of things you would see.
We have a few minutes left, and I just want to throw out a couple myths about schizophrenia. Okay. One of which is people with schizophrenia will always become violent. Can you speak to that? Because yes. There's a lot of talk about.
Right, so that's, obviously with some of the catastrophes that have happened in the last few years in Colorado and in my state in Sandy Hook, Connecticut, where people who are very, very troubled committed these just horrible crimes, it gets everyone very frightened. My understanding of the statistics on this is in terms of violence, about 5% of the violence is committed by people who might be psychotic. It's not necessary. It's not typical of schizophrenia, but it can happen.
Yes.
the more common thing in terms of violence is suicide. And it's
violence to the self, really.
Violence to the self, exactly.
I see.
And the risk of that is a bit less than 10%.
I want to finish up with a question about families and
Yes.
friends. You have, I imagine, countless encounters with families and friends of people who are suffering from schizophrenia. What advice would you give to people who love someone suffering from this illness?
You know, when I started doing this work over 40 years ago, and you know, you would talk with a family about the child having schizophrenia, it was as though you were telling them their child had cancer. They saw it as, this is the end of the road, maybe they'll live for several years, but you know, people grieved. They just thought, there's nothing I can do here. And that's really not the case. I think that there are a number of things one can do. The most important thing is that as a parent, yes, you have to readjust your thinking about what your child may need and what your expectations are. But when the child has an episode and goes back home and lives with family, and the family is working together with supportive counselors, people do pretty well. And so I think, you know, the first thing is to love them and be supportive. The second thing is to be educated, to learn as much as you can about the disorder and how to best be helpful. And the patient also needs to learn that. So you do that together. Those things are useful. For some people, there may be some changes in lifestyle that become necessary. And you know, again, thinking those through together as a family can be very helpful. The other thing, as a practitioner, you know, working with schizophrenic patients, I've always found it very, very helpful to have one, often two, people in the family that I talk with, other than the patient, because you often need collateral sources of information, and you also need other people to help provide support for the patient, and the family and close friends generally are the best people to do that.
Yes. Well, thank you so much, Dr. Possick, for giving your time. This is such an important topic and so important that people know more about it. So I look forward to your presentation tomorrow, and so do a lot of other people who are coming tomorrow. And thank you again.
My pleasure.
Thank you so much for joining us again for Keep Talking. I want to put in a plug for our Stand Up to Stigma campaign. We have these great bumper stickers and if you call me, I'll send you a bumper sticker. This is Stand Up to Stigma, and we still want to make this a very important part of the message from the Brattleboro Retreat. We look forward to bringing more programs about mental illness and addiction care to you out in the BCTV audience, and we thank BCTV for all their support and all their help. We couldn't do this without them. And please join us again.